These are endless. All right, let's get right into it. We're talking about the clinical pathway for deliberate hypotensive anesthesia. So what's the core idea here? It's pretty straightforward. We intentionally bring a patient's blood pressure down to a specific target. But, and this is the critical part, we only do this while making absolutely sure that we're preserving end organ perfusion. So let's be really clear about the stakes right from the get-go. The evidence on this is pretty stark. Research from the Cleveland Clinic shows that if a patient's MAP drops below 65, even for just 13 cumulative minutes, it becomes a major red flag. We're talking about a direct link to increased risk of acute kidney injury, myocardial injury, stroke, and delirium. This is not a theoretical risk, It's a hard number, a critical safety threshold that we just have to respect. Okay, so here's how we're going to break this down. First, we'll cover scope and risk stratification. Then, we'll walk through the preoperative and intraoperative management. After that, we'll tackle the special case of the beach chair position and cerebral protection. And we'll wrap it all up with postoperative management and a safe handover. All right, Section 1, scope and risk stratification. Look, if there's one thing you take away from this part, let it be this. The single most important safety mechanism for this entire technique is choosing the right patient. It all starts here. So, how do we do that? We stratify patients into 3 main buckets: low, moderate, and high risk. This is all based on their comorbidities and functional capacity. And this stratification directly tells us what our MAP target should be. For a low-risk patient, we might feel comfortable targeting a MAP between 60 and 65. But for a high-risk patient, we've got to keep that MAP much higher, somewhere in the 70 to 85 range. And let's be honest, for a lot of those high-risk folks, the right answer might just be to avoid this technique completely. And of course, there are some hard stops, absolute contraindications. We're talking things like a recent stroke or TIA, critical coronary artery disease, severe aortic stenosis, or decompensated heart failure. If a patient presents with any of these, this technique is completely off the table. Think of it as a non-negotiable safety gate. Okay, moving on to Section 2, the preoperative protocol. What are we trying to accomplish here? Really, it's 2 main things. First, we need to establish a really solid, validated baseline blood pressure. And second, we need to make smart calls on their home meds to set ourselves up for stability in the OR. And we have some pretty firm cutoffs for when to proceed with these elective cases. For instance, if a patient's blood pressure is sitting at 180 over 110 or higher, we defer. Simple as that. The priority has to be getting their antihypertensive regimen optimized before they even get to the operating room. Now, what about their meds? Well, for chronic beta blockers and calcium channel blockers, the standard is to continue them. We want to avoid any withdrawal issues. But for ACE inhibitors and ARBs, it's a different story. We typically consider holding those for about 12 to 24 hours before surgery. Why? To reduce the risk of that stubborn, refractory hypotension we can sometimes see intraoperatively. All right, on to Section 3, intraoperative management. So once we're in the OR, we're not aiming for one specific magic number. Instead, we use what's called a target corridor approach. The whole idea is to keep the MAP safely inside a predefined range that's tailored to that individual patient. And here you can see those corridors, and you'll notice they tie right back to that preoperative risk assessment we did. For your low-risk patient, that corridor is 60 to 70. For moderate risk, we're looking at 65 to 75. And for our high-risk patients, we need to keep them in a higher corridor, from 70 up to 85. It's crucial to remember that any dip below the floor of these corridors demands an immediate response. So what do you do if the MAP does fall below that floor? We trigger an immediate response protocol. It's a really clear step-by-step algorithm. First thing, check for causes. Is there surgical bleeding? Next, reduce your anesthetic depth. Then, give an IV fluid bolus. If that's not enough, start a vasopressor. And if the patient is still unstable after all that, you have to be prepared to just terminate the technique. Now for a really important topic, the beach chair position. This is Section 4, and it's all about cerebral protection. This position creates a unique, gravity-dependent risk to cerebral perfusion. Because of that, using specialized monitoring like cerebral oximetry isn't just a good idea, it's mandatory. And the reason why is pretty staggering when you look at the numbers. The incidence of cerebral desaturation events, CDEs, in the beach chair position can be anywhere from 17 to 80%. This just hammers home a critical point. Your standard arm cuff reading is dangerously unreliable in this scenario. It will almost always read higher than the actual perfusion pressure getting to the brain. So instead of just the cuff, we use these specific predefined thresholds from the cerebral oximeter to trigger our interventions. Think of it like this. A drop of more than 15% from baseline is your first warning sign. But a drop of 20% or more, or if the absolute value dips below 50, well, that's a critical event, and you need to act right away. And when you do see that desaturation, there's an escalating protocol to follow. You start with the simple stuff, right? Check the head position, make sure there's no kinking. Then you move to physiological maneuvers. Raise the map, optimize their oxygenation and their CO2. And if things still aren't getting better, the final, definitive move is to lower the chair and get the patient out of that compromising position. Okay, that brings us to our final section, post-operative management and handover. Look, our job doesn't stop when the surgeon puts down the knife. A safe transition of care means we have to stay vigilant and give a really clear, concise handover to the PACU team. And what does that handover need to include? Well, it has to spell out the target blood pressure range, and it needs to specify which organ systems need an extra close watch. We're talking about key parameters for cardiac, renal, and neurological systems. Looking for any signs of ischemia, keeping a close eye on urine output, and doing a careful assessment for any new neurodeficits or delirium. So let's wrap this up. It's really important to remember that controlled hypertension is an advanced technique. It's not something to be taken lightly. It demands senior-level clinical judgment and, just as importantly, strict adherence to a structured pathway. And at the end of the day, never forget the primary goal. We're not just chasing low numbers on a monitor. The real goal, the only goal that matters, is ensuring adequate organ perfusion. So I'll leave you with this question to take back to your own practice. Does your institutional protocol specifically address these critical evidence-based thresholds for both MAP and for cerebral oximetry? Taking a fresh look at your own protocols might be one of the most important